Hello everyone, very good evening. I am Dr. Sunil Jindal and I take care for Medical Affairs and R&D Department for Baxter Advanced Surgery, India and South Asia. First of all, I would like to extend my warm welcome on behalf of entire Baxter team to all the eminent speakers, organizing chairpersons, participants to this webinar on Cerebello-Pontine Angle Tumours. Baxter Advanced Surgery is a division dedicated towards bringing the best outcomes in surgical practice and providing the support to surgeons in achieving hemostasis and sealing of tissues. This is our first session in 2021 under the theme of Tumor Thursdays, which was conceptualized to have a very meaningful discussion around neurospinal tumors, right from basic concepts like pathology, diagnostics, and up to surgical management. Baxter Advanced Surgery is proud to be associated with Dr. K. Sridhar and MGM Healthcare, and I would like to take honor to introduce organizing chairperson and speaker for today's webinar, Dr. K. Sridhar. He's a director and group head Institute for Neurosciences and Spinal Disorders at MGM Healthcare, Chennai. Sir is a renowned neurosurgeon with over 30 years of experience in his specialization, trained under pioneer neurosurgeon Professor B. Ramamurthy. He has established Center of Excellence in Neurosciences centered around the concept of integrated neurocare. His experience and expertise in spinal surgery, brain tumor, and vascular surgery and in pediatric problems is well known. He has done pioneering work in microneurosurgery, especially in brainstem and eloquent area surgery, including awake craniotomies and cervical spine surgeries, and also in neurotrauma. He has got several publications, both in national and international peer-reviewed journals to his credit, and has edited certain textbooks in neurosurgery. With this introduction, let me welcome Dr. Sridhar to take the session forward from here. Over to you, sir.
Thank you, Sunit. Thank you, Abhishek, and thanks to Baxter for restarting the Tumor Thursday program. We had done 4 of these in the previous year, and now we are restarting it to complete the entire cycle of Tumor Thursdays. I would like to thank our eminent and distinguished panel of moderators and speakers. First, I would like to introduce our moderator, senior neurosurgeon, Professor Suresh Nair. We all know Professor Suresh Nair is a very eminent past president of the Neurological Society of India. He is also the president-elect of the International Meningioma Society, and he has been previously the dean and professor of neurosurgery at Sri Chitra Tirunal Institute of Medical Sciences, and also has been the professor of neurosurgery at AIIMS Bhopal. Welcome, Professor Suresh Nair, and we know that the CP angle and especially acoustics are a favorite topic of yours, and we are hoping to hear your words of wisdom during the discussion. Thank you so much for being here.
Thank you, Sridhar. Thank you, Sridhar. Yeah.
The next distinguished moderator of the evening is Professor Ajit Sinha. Professor Ajit Sinha completed his neurosurgery training from PGI Chandigarh in 1997 and has been working in Sir Gangaram Multispeciality Hospital, New Delhi for the last 22 years and is presently the Vice Chairman of the Department of Neurosurgery at Gangaram Hospital. He has also been a teacher, a guide, a co-guide of DNB Neurosurgery at Gangaram Hospital, and his area of interest is skull base and vascular neurosurgery. He has actually published and has significant experience in a novel technique of PEPE, which is the pterional extradural purely endoscopic technique for CSF rhinorrhea repair, and has been and is still a very commonly heard lecturer and speaker in many national and international conferences. So welcome, Professor Ajit Sinha, to our Tumor Thursday webinar, and thank you so much for coming here. I would like to inform all the attendees to kindly post your questions in the Q&A box so that the chairpersons and moderators can look at these questions and then can put this to the panel. And also, I need to inform you that we are going to be one speaker short. The talk on clival chordomas is being postponed because Professor Rahimli from Azerbaijan is not able to join us today. So we will not be having that talk. So I will now pass the baton on to the moderators, Dr. Suresh Nair and Dr. Ajit Sinha, for taking the proceedings forwards. Thank you.
Yeah, Ajit, you can start, Ajit. Yeah. please.
Sir, you start. You're
No, please, Ajit. You can start. Please, Ajit.
Okay,
please.
okay. Since Dr. Nair, sir, who is like my teacher, he has permitted me, so I take this responsibility. And I welcome all the participants and the speakers. And I was very, very enthusiastically looking forward for this meet, in which very interesting topic of the posterior fossa tumors, especially the common tumors like acoustic neuroma, meningiomas, and hemangioblastoma to be discussed. So I welcome all the speakers, and without wasting time, I would like that our first speaker, Dr. Mathews, who is going to speak on vestibular schwannoma. He can start with stuff. He's the
I will just introduce Dr. Mathew Abraham. Mathew Abraham was my student at Chitra Tirunal Institute of Medical Sciences. He is an exceptionally talented surgeon. His area of interest is vascular surgery, where I think he has done more than 1,000 aneurysm cases. And also now, after I left Chitra, he has taken over skull-based vestibular schwannoma surgery. And also is a pioneer, everybody knows, in epilepsy surgery. Exceptionally good surgeon. And looking forward to this lecture from you, Mathew.
Thank you, sir, for all the sweet words. Thank you, Dr. Ajit. Is my screen visible?
No, not yet.
You need to share it.
Yes.
Yeah, I've shared.
Yeah, now it is visible.
Now it's visible. Okay. First of all, let me thank Dr. Sridhar for giving me this opportunity and Baxter for providing the logistics of this meeting. It's a great honor for me to present this topic in specific with Professor Suresh Nair as my teacher and my mentor in the chair. And I must confess that today I feel more like a postgraduate presenting a seminar, because most of what I have learned about the tumor, almost all that I've learned about vestibular schwannoma is actually from Sir only. And I hope all my deficiencies will be ironed by him as the topic progresses. Now, into the topic. Vestibular schwannoma is actually 85% of vestibular schwannomas form 85% of all CP angle tumors. And over 90% of them arise from the specific nerve that is the inferior vestibular nerve. So why is that so? The Obersteiner Ridge zone, that is an unstable area where the oligodendrocytes give way to the Schwann cells, is actually 1 centimeter in length, or perhaps more, when it comes to the vestibular nerve. It's only 1 millimeter. If you see the other nerves, it's just 1 millimeter. But when it comes to the vestibular nerve, it is almost 10-fold longer. So that is why this great preponderance for a tumor on this nerve. This zone is at the porus in around 56% of patients, while it is in the canal in around 44%. We all know that the first successful surgery was done by Dr. Charles Ballance, Sir Charles Ballance. Vestibular schwannoma surgery has evolved. It's no longer a life-saving procedure. It is a procedure to preserve function and quality, as well as to achieve oncological control. The surgery is no longer an option, but it remains. It's no longer the only option, with several other possibilities like radiation. We know the epidemiology, even observation, but surgery still remains the gold standard. I shall first go into the special concerns of this lesion. Vestibular schwannoma is never a surfacing lesion. It is a deep lesion. So all the principles that you use for a superficial tumor on the brain cannot be applied here. It is not only is it deep, but it is also within the bone. A good part of it is within the bone. It is intimately associated with the brainstem, as well as the blood vessels that grow to the brainstem. It is under cover of the cerebellum. It is something that is deep to the cerebellum. It is covered deep inside the cerebellum. It is tightly draped by the cochlear as well as the seventh nerves. The lower cranial nerves comes in a very adjacent nearby cistern. It is separate, but in a very adjacent cistern. The trigeminal nerve is in close approximation if the tumor grows to large sizes. It's highly vascular, and as it enlarges, it has a tendency to take blood flow from new areas. I'll keep this talk basically to technique and predominantly from the retromastoid approach. When it comes to technique, I would, rather than calling them approaches, it is better to call it trajectory. In entire neurosurgery, it's a trajectory that matters. How you approach a lesion, the direction or the trajectory in which that decides the all the structures that you have to deal with and its final success. So you have a retromastoid trajectory, you have a middle fossa trajectory, and your translabyrinthine trajectory. And now the second aspect of the technique is the electrophysiology behind protecting the function. So you have the trajectories and the electrophysiology. This sums up the entire methodology of approaching this tumor. When it comes to electrophysiology, it is these two nerves that are important, the seventh and the eighth nerve. The seventh nerve can be protected, preserved, or you can keep a continuous watch on it with a continuous free-running EMG that is widely available, or an evoked EMG, that is, you give a stimulus and you see whether the nerve is functional. There is a different levels of using the evoked EMG. You can have a stimulus threshold method, that is, you can measure the threshold of stimulus. You can have a response amplitude, what is the amplitude for a specified response, and you can go for a proximal to distal amplitude ratio. Very often, we may not be able to utilize the entire spectrum, but the evoked EMG remains perhaps one of the most effective ways of localizing as well as tracking the seventh nerve. With regard to the eighth nerve, the evoked potential, the auditory evoked potential is well known, but it's a far field measurement. Slow, the averaging reduces its accuracy. There is a delay of almost 0.8 to up to 2 seconds sometimes when you get the responses back. It may not give a direct feedback to the surgeon sometimes. There is the short field measurements where you get a more larger volume of information and the latency period is less. There is a compound nerve action potential where you directly get responses from the eighth nerve, and the electrocochleography, otherwise called the ECOG. These two have a much higher amplitude, but also have certain pitfalls. Now I will basically start with the three approaches first and then go into the retromastoid. This is a posterolateral trajectory. So this is from posterior and from lateral. It gives the widest vision. We are most familiar with this trajectory as neurosurgeons. It gives the best opportunity to preserve the nerve, the seventh, the eighth nerve, to protect the brainstem. The cerebellum, however, the structure that is most vulnerable, we all know, is the cerebellum, because the cerebellum comes in the way. In the posterolateral trajectory, the cerebellum that stands between you and this tumor. However, if you can tackle this whole problem becomes much simpler. It is good for any type of tumor, irrespective of the size, irrespective of the level of adhesions, its location within the bone, or involvement of any other tissue. It is the best approach for it's the best default approach. The translabyrinthine approach, it is a lateral trajectory. It's like being directly on the lesion. It's not directly on the lesion, but it looks as if you're directly on the lesion. If you see, it has to compromise the hearing apparatus to reach it. So this is the picture where you approach it directly towards the tumor. The posterior aspect is avoided. You go lateral, that means you avoid the cerebellum. So this gives the best opportunity to protect the cerebellum. However, you have the hearing damaged. At the same time, the seventh nerve is at a greater risk. Statistically, the seventh nerve risk is higher. Why? Because we have these are the entire the course of the seventh nerve. You have the pontine or the cisternal portion, then you have the meatal portion, you have the labyrinthine portion, tympanic and mastoid. You have to expose most of this and almost the entire seventh nerve during this process. The tympanic portion is perhaps the most vulnerable as far as the vascular supply is concerned. and the nerve risk may perhaps be higher. However, the advantage is that because you come from lateral, you don't face any brain bulge. Your trajectory is expanding. It's a conical approach expanding. So you have the chance of, you can tackle any size lesion with this approach. The middle fossa approach is actually the simplest of the approaches. It comes straight down. Yeah, as soon as you identify the GSPN, you know where the IAM is. You come down, you just remove the bone, and you have this here. However, the seventh nerve is at a greater risk because of a sandwich effect, it's called. Then the seventh nerve presents itself through the dura as you open the dura. You have to push it aside, or you have to work amidst the seventh nerve to remove the tumor. But here you're tackling only with the meatal portion. You don't expose the labyrinthine portion or the tympanic portion of the seventh nerve. This is a much less vulnerable zone of the seventh nerve, the meatal portion. And hence you're likely to get a reasonably good seventh nerve outcome, even if you have to manipulate it. However, it's good only for small tumors. It's the best approach for preserving hearing. I shall go into the details of the retromastoid approach as well as demonstrate a moderate size lesion to bring out the nuance of this procedure. There is little, we all know there are two approaches. There is nothing very controversial about it. It depends on your viewpoint. You can have, if you want to sit and operate, or if you want to avoid hand strain, if you're going for a very prolonged work, you may prefer this approach, that is the park bench, the lateral approach, or you can go for a sitting approach where the gravity drains the blood and gives you a better field sometimes. However, there is a chance of arm strain as well as a slightly more difficult microscopic position. We all know the craniotomy is centered here, the asterion, the junction between the parieto-occipital as well as the parieto-occipitomastoid and parieto-mastoid sutures. The initial burrow is placed here, and you make a craniotomy approximately of this size. You can expand it in all directions. You can expand predominantly in the anterior direction. You can even do a combined translabyrinthine. You can combine this with the translabyrinthine if you require. You can expose this entire sigmoid sinus if you want, or you can expand towards the base, or you can contract your approach more towards this direction. These are all your choices. Here again, the part of the seventh nerve that you interact is the cisternal as well as the meatal portion, which are reasonably tough regions to handle. I shall demonstrate one case. This is a 62-year-old lady who had a person with hearing loss. There is a 50 decibel hearing loss, with a speech discrimination of 50% and no seventh nerve involvement. So this is the lesion. This 30 millimeters and 29 millimeters in size. This is lying in the cistern here. This is a Fiesta scan. You can see the opposite nerve as well as the cochlea here. I shall first go into the initial approach towards this tumor. So I've done a retromastoid craniotomy, and I find the cerebellum is marginally full, not too full. The most pleasurable sight in neurosurgery is to see the CSF draining out. I've pushed the cerebellum slightly down, and I'm releasing CSF from the cisterna magna. This is perhaps a very critical initial step. Now, there is no hurry in putting your retractor here. You have to get the plane out. This is perhaps one of the most important teachings of Suresh Nair, sir, that is, you have to go to the inner arachnoid plane. However you dissect, you are likely to have a deeper plane. You have to be really on the tumor. If you slip out into the subarachnoid space, this is a deadly tumor, particularly on its front with the brainstem. So as you remain very close to the tumor, go through the deeper to the inner arachnoid plane, the lesion behaves better. So I am gradually dissecting this plane. You can see the tumor is bare, no blood vessels, no arachnoid lying on it. The tumor is opened. These vestibular schwannomas are highly vascular lesions. They are at small sizes. The predominant blood supply is from the IAM, but it can get blood supply from the ICA branches, other branches of the ICA. I prefer to use for the finer arachnoid. For the thinner arachnoid, I prefer to use a scissors, which the tip of which is opened mildly. So as you open, it becomes a tougher instrument. As you make it closer, it becomes a more gentler instrument against the arachnoid. And as you expose more and more of the tumor, more and more decompression is to be initiated. Both are complementary to each other. There is no role of dissecting this tumor from one direction at all. This is perhaps one of the mistakes that one can do. The tumor should be approached from a multi-directional plane. If you approach from one side, you put undue traction on all the structures that are attached. So I'm gradually, I hope my video is clear. Okay, this, as you expose the tumor, the CUSA is used to decompress. I salute the earlier surgeons who have operated without a CUSA. I find it should have been almost impossible now to think of decompressing this lesion without a CUSA. The arachnoid is this one. I'm still on the peduncle. I've not yet reached the main regions of the brainstem. I'm still on the peduncle. And as the tumor is decompressed, you don't have to give a large handle. The handle can be removed periodically. You need an assistant who holds the tumor very patiently. There should not be any traction. He just has to expose the region adjacent to you and irrigate as at the border to expose the tissue for you. So this instrument, I would say, is a very useful one, and this combined with a very sharp tooth forceps gives great leverage in exposing the tumor. If the plane appears too simple, you are in a subarachnoid plane and you're going to create damage. And if the plane is too difficult, you may be going into the lesion. So the plane is reasonably difficult and it taxes you. So the multi-directional approach goes into either pole. It can go in both into superior as well as inferior. I prefer to go towards the superior and lateral regions in the beginning and leave the inferior portion towards the end. The inferior portion actually will not bother you much, and the inferior and the lower cranial nerves actually have an excellent arachnoid plane from the tumor, which will actually may not even come into your view, particularly in a smaller tumor. After a thorough decompression has been obtained and after the tumor seems to be floating, the next step is to achieve some temporary hemostasis. If you see, I have not used a monopolar almost during the entire procedure. The more and more of a bipolar that you use, more likely you have to produce vascular as well as nerve damage. So at this stage, I've used some Surgicel to control the bleed. Now, the next stage is to protect the nerves. So this is actually an article from China where they have described the different appearances of the nerve. So in this one, you have a normal type, that is, you have a rounded nerve coming posterior to the tumor, and this is seen in around 3.4% of patients. And this is the flattened type. This is the commonest, seen in more than 70%. And this is the membranous type. This is particularly important. It's actually impossible to dissect a membranous seventh nerve safely. So it's better in these sort of cases. The tumor should be decompressed to the very minimum, and then the flattened nerve converts itself into the membranous nerve converts itself into a flattened nerve, and then perhaps you can dissect it better. You have a penetrating type of seventh nerve here, where maybe it is often seen when there are multiple foci from which this tumor is growing, and you may have to leave a portion of the tumor to protect this nerve. And this is the diffuse one, perhaps the most difficult. And you may take out the tumor nicely, but you will find that there is no anatomical continuity. So this is perhaps the most tricky one. Now I will go into the seventh nerve preservation aspect of this tumor. So I have decompressed this tumor. This is the same lesion. I have decompressed the tumor reasonably thoroughly. And now I'm going for the IAM. I've just removed the dura from the IAM. And the drilling is in progress. This is actually a very heavy video. So that's why it is getting slow. The drilling of the IAM is, the target is to reach the fundus. The fundus is the deepest portion of the IAM, and the limitation of reaching the fundus is often a difficulty in trajectory. Here, fortunately, I am able to reach the fundus. The larger drill bit, the larger diamond drill bit may be more efficient in doing this than a smaller one. You can see that I have drilled the entire superficial surface of the posterolateral surface, and I'm using a hook. A hook is perhaps the safest tool when you are afraid of traction. If you use a forceps, if you use a tooth forceps, you give undue traction. A hook has a limitation. A small hook will slip off as soon as your traction increases. So this is the 7th, 8th complex, the remnants of the 8th as well as the entire 7th getting exposed within the IAM. I'm using my scissors, a downward curved scissors to initiate my lateral dissection. There is no need to isolate the 7th nerve. My feeling is that there is no need to isolate the 7th nerve at this stage. The entire posterior plane, which consists of whatever residual, what do you call it, 8th nerve or whatever arachnoid, whatever tissue is there, you can preserve that and dissect it away from the tumor. Now I've left that zone. I'm again going laterally, emphasizing the multi-directional nature of a dissection. Now, by coming back again to the brainstem, you have to dissect in a plane which is closest to the tumor. Here, the brain has to be dissected away from the tumor rather than the other way. The tumor has to be is reasonably static and the brain comes off. This is the trigeminal fibers coming through. Here, you have to go a little outside the arachnoid, outside this arachnoid plane. But again, you can recover. You have to come back into the within the arachnoid as soon as possible. You should not. It's an error to persist with this plane, because as you go more medially, it will directly interact with the vessels, as well as you'll go on the other side of the 7th nerve. I'm again back to the IAM side. This is the IAM, and I'm continuing my dissection. Even now, if you see, one shouldn't use the bipolar cautery to any major degree. All the bleeding can be controlled with pressure and with some Surgicel. So you can see most of the tumor has been rolled out. Again, I'm using a hook, and this contains the entire 7th nerve as well as whatever portion of the 8th nerve that is left. Always cut, never pull. When you are having some tissue that is hanging or attaching, think that it is going to be the 7th nerve, and always cut and separate in a plane closest to the tumor. Now the tumor has come out. You can see I'm using a bipolar stimulator here, trying to localize. This is not I'm not having sound here. Actually, the 7th nerve is coming down like this. And this is the choroid plexus coming out through the foramen of Luschka. This irregular tissue is the foramen coming through the foramen of Luschka. So this is the direction of the 7th nerve here. Yeah, that is being demonstrated here. So so this was the post-op scan of this patient. If you see, there is a small improvement in the hearing. The loss became from 50 to 40 decibel, but the speech discrimination never improved. Whether this hearing became useful to the patient is not clear to me. There was no 7th nerve palsy at all, fortunately. And you can see the remnant of the, you can see the 7th nerve as well as the remnants of the 8th nerve. This is my personal experience. It's I'm a relative beginner. I have stood on Suresh Nair's shoulders to have a look at this field. 162 cases over the last something like 3.5 years. I have 22 patients less than 30 millimeters, 134 patients more than 30 millimeters. And this giant tumor series has dominated, the 109 has dominated my experience. And the mean size is 46 millimeters and the median size is 45 millimeters. Anatomical preservation, that is, you get an anatomical nerve. I have managed in almost 144 patients. Anatomical and electrophysiological, that is gross electrophysiological. I admit that I'm not able to clearly differentiate the extent of electrophysiological preservation, because at that stage, it becomes a little difficult to differentiate between the amplitude levels or the proximal to distal ratio of this, the amplitude. We could manage around, in 77.7% patients, we could get some form of electrophysiological preservation. And in less than 30 millimeter tumors, almost all patients, we could get anatomical and electrophysiological preservation. The seventh nerve functional preservation overall, that is when you take House-Brackman up to 3, where you can get eye closure with some effort, the outcome has not been as great. Frankly, perhaps I have a longer learning curve, 46%, while the electrophysiological outcome has been 77%. Maybe I have to make this electrophysiological monitoring a little more effective, 46%. But when it comes to 30 millimeter, less than 30 millimeter lesions, the outcome has been 82%, 18 of the 22. This is the follow-up point, either at immediate post-op or at 6 weeks post-op. There are 3 mortalities in my series. Thank you.
Ajit, you can ask something, or we can take discussion at the end of the session.
Yeah.
Yes, sir. We had decided that
let's
we'll
take
take
discussion
the
at the end of all the talks. Yeah.
Okay.
Right,
Okay. Now, let me introduce the next speaker. He is again one of my very close friends, or what I call colleague or student or whatever it is. Dr. Roopesh. And everybody knows Roopesh because he passed out from NIMHANS, Bangalore, and I was his examiner that time, and one of the best students who has passed out with flying colors from NIMHANS. And it was not surprising that he was immediately absorbed as a faculty at JIPMER Pondicherry, where he was also heading the department. And then he worked there for a long time, and then switched gears to corporate setup. He went to Chennai. He was working with Suresh Babu for another long time. Now he has switched over to another big corporate setup. And he's an exemplary good vascular surgeon. Everybody knows. He's a very good skull-base surgeon. He has eloquent area surgery. Like Mathew, he has put his footmark everywhere. And I am looking forward to your lecture on CP angle meningioma. I don't know whether it is CP angle or you are going to talk about petroclival also. Over to you, Roopesh.
Thank you very much, sir, for your kind words. Indeed, it's a great pleasure to talk before you and Dr. Ajit Sinha. And you are always inspired us on this topic of cerebello-pontine angle. Thank Dr. Sridhar for giving us this opportunity. Let me share my screen. So we heard Professor Mathew, who is also my close friend, who spoke about vestibular schwannomas. And this topic is almost close, but not really very close to the vestibular schwannoma. So I will concentrate on cerebello-pontine angle, the meningiomas in and around cerebello-pontine angle lesion. Actually, it was described first by Professor Harvey Cushing and Eisenhardt in 1938, because they were looking at some tumors which are closely mimicking vestibular schwannomas, but they are not really so. So that they called it as simulatory tumors of vestibular schwannoma, and they constitute around, they're not very common like vestibular schwannoma and CP angle. So they constitute around 10% of the CP angle tumors. They have various origins depending on the location which I'll talk, but generally the petrous dura, the dura of the tentorium, so they are a little bit heterogeneous, not like a stereotypical origin like a vestibular schwannoma. Dr. Mathew has already covered up the surgical anatomy in his lecture. So the specific thing is that unlike vestibular schwannomas, where the only seventh nerve is very closely adherent, the rest all have a beautiful arachnoid plane. Whereas the the meningiomas, they have the tendency to encase the nerves, encase the vessels, which is not the character of schwannoma. And we see in a subset of patients with bony hyperostosis, and very, very commonly we see in a large tumors, there will be invariably some amount of pial invasion, and there will be a lot of edema of the cerebellum and brainstem. So that is how they differentiate themselves from vestibular schwannomas. Radiologically, I'm sure that there will be some residents and fellows. So this is just to distinguish cerebello-pontine angle, the radiology, how a vestibular schwannoma and meningioma, they differ from each other. So we know that the vestibular schwannoma are centered in the IAC, whereas the meningiomas are not really. And the main thing is the broad attachment. As you see here, they have a very wide attachment to the petrous dura, and they have formed this typical internal acoustic meatus. Though these tumors enter into the acoustic meatus, they never widen it. So you'll see a normal IAM vis-a-vis in vestibular schwannoma, where you always see some widening of the internal acoustic meatus. You also notice that there is an obtuse angle of the petrous dura towards the tumor. The angle is wide, unlike narrow acute angle in vestibular schwannomas. Of course, if you see a hyperostosis, then most likely it is a meningioma which you're dealing with. So these are some of the radiological hallmarks, how you differentiate meningioma of a vestibular schwannoma in this particular location. However, one thing which you need to really put your foot down and examine is the T2 weighted images, which will give you a lot of information for your surgical planning and the characteristic of the tumor. As you see here, it's a contrast enhancement seen, but then you see the tremendous amount of edema, which you don't see in vestibular schwannoma, because this meningioma incites a lot of this inflammatory response, edema, and this says that the pia is breached. You can see that the brainstem also has edema, so you know that you're not going to get a good plane there, and you may have problems when you're doing surgery in this particular location. So this will give you very, very important information on this edema. Always you should look for the T2 weighted image. And the other thing is that, as I was mentioning you, typically the meningiomas encase the vessel. So as you see, the basilar artery is partially encased. So this is some very, very crucial information which you have to really look for it, especially in the T2 weighted, heavily T2 weighted images, and this helps in your surgical planning. Grossly, surgical aspect, we can have these tumors as a premeatal or a postmeatal. Clinically, how premeatal tumors generally they present early because they present with the early cranial neuropathy, most commonly a trigeminal neuralgia, hemifacial spasm. So they present early because of this, even their small location. Unlike postmeatal, where slowly progressive lesions, they can grow to a large extent before they manifest themselves. I was going through letters that not much of classifications of cerebello-pontine angle meningioma. They don't come under one umbrella like a vestibular schwannoma. So there are varied locations of these tumors within this cerebello-pontine angle. So there are Kumar et al. He has classified them into 4 groups. One is the tentorial type, wherein you see a tumor attached to the tent, and then they come also attached to the petrous dura. So they form that angle, where is the tent, the petrous, and then they go till the petrous apex. So that is the type 1 or the group 1. Here the 5th nerve is shifted more anteriorly or medially. The petroclavial one is the one, the most difficult one among these. Here you see that the tumor is medial to the 5th nerve. So you see the nerve first and then the tumor later. And here the nerve is pushed laterally, and that is the most challenging type of the tumor. Anterior petrous, again, the attachment is towards the dura of the anterior petrous bone, and 5th nerve is typically displaced medially. Posterior petrous are the easier ones compared to all these things because they present themselves first, then only you see the rest of the structures. Coming to the management options, you have, if it is a small meningioma, not incidental finding, not much symptoms in elderly people, you can manage them conservatively. You need not really jump into it and operate. Any tumors with mass effect and the neurological dysfunction, you straightforward go ahead, decompression. SRS, stereotactic radiosurgery, is indicated either as a primary treatment in small growing tumors or as a postoperative adjunct to leave behind nodules around the nerves and vessels, which starts growing on your follow-up scan. Coming to the surgical approaches, I think that Mathew also had described various techniques, but here retrosigmoid again is the main workhorse for these cerebello-pontine angle meningioma. However, there are some tumors, especially if the tumors are more anterior, one can come transpetrous, anterior petrous abruptly. Nowadays, of late, the endoscopic also is coming into view, and some medially placed lesions can be approached by extended endoscopic approach. I'll be showing you some videos of that. So typical retrosigmoid, the bar pinch position, you can have various incisions. Either you can make a small C, you can make a lazy S, you can make a linear. And so typical how the same position for a vestibular schwannoma. So the standard retrosigmoid. So you always keep a thigh graft ready, because most likely you may need a good facial dural reconstruction and also to harvest fat. The principles of surgery are pretty the same as any skull-based meningioma. So adequate exposure, devascularization of the tumor. Devascularization sometimes it may not be possible all the times, because sometimes it's more deeper. You may not be able. You may have to debulk some tumor before you get into the devascularization, and significant decompression before dissecting of the neurovascular structures. So this is the same. So a good arachnoid opening is mandatory. So you need to have so that the cerebellum will really fall back, and then you can have a nice plane around it. And you can see here that you start opening the arachnoid, and slowly as you do so, when you release the CSF, your cerebellum automatically gets mobilized. So you need not use a retractor there, and because retractor itself will be posing a damage, and you can use your suction as shown here as a dynamic retractor. And you can see that, so you start stripping the arachnoid. Dr. Mathew was mentioning very nicely that the tumor should be matte finish, so that means you're in the good correct plane. The same way, holds true here also. So you try to strip the arachnoid and make the tumor raw, and then so that you start working on it. However, you should always know that these meningiomas can encase the nerves and vessels. So even if you are stripping the arachnoid, you're not very sure that you may not injure the vessel. So always you should be very, very watchful and keen. So as you see, he start mobilizing the arachnoid, slowly peel the arachnoid and make the tumor raw, and then you're seeing there, that is the Dandy's vein, so superior petrosal vein. You try always to preserve it. You don't sacrifice it unnecessarily, because sometimes you may never know which patient you will end up into problem. Cerebellum can bulge, and then already the cerebellum will be bulging in large meningiomas. So you nicely open the arachnoid and start stripping. So that is the principle of any meningioma surgery, more so in the CP angle. So as you start doing that, then the next step is you start devascularizing it. So you can see that sometimes these meningiomas, they get blood supply from the external carotid artery. So it can be extremely vascular. So you start decompressing. Before decompression, you try to devascularize the tumor. So you make the tumor less vascular for you to debulk. So that is the way you go ahead. So external, once you devascularize it, you can see that the blood supply comes down, and then you can start working on the tumor more and more. I'll show you some more videos on that. So the internal debulking using CUSA. CUSA is very, very essential here. And once you decompress fairly good amount and arachnoidal opening, so you start cutting the arachnoid, and then you deliver the tumor, and then finally you see. So this are the roughly these pictures I have taken from Aaron Cohel's neurosurgical atlas. They are extremely good, and it's for teaching material. And so I will show more detail the video. So intraoperative neuromonitoring, yes, we can use BERA. Facial EMG, especially if the tumor is very close to the seventh nerve, and if the tumor comes down to the jugular foramen, you can also use lower cranial monitoring. The first type, as I showed you, is the petrotentorial type. As you see, the tumor gets attached to the tent as well as to the petrous dura, and that is something like this. So you can see that. So you always expose, you need not completely expose, but at least you see the edge of the transverse sinus and sigmoid sinus, so that you don't have much retraction. So as you start retracting the cerebellum, you will start seeing this tumor there. You can see the leash of vascular channels on the capsule of this tumor, and you can see that there's no retractor there. So once you open the arachnoid nicely, the cerebellum will fall back itself, and you are using your suction as a suction dynamic suction retractor. And then you start debulking. So you start devascularizing, but here you can see that you cannot go. This tumor is widely attached to the tent as well as to the petrous. So it's very difficult to go in. So first you start debulking the tumor, and then somewhere in between you go to the attachment and you start. You can see sometimes they can be extremely fibrous. So you can see you have to cut with a 11 blade, and then you start using QSA to decompress the tumor and more and more. You can see that luckily not much vascular unlike the previous case. So you make a nice window of that, and before you enter the tumor, and you have a good window through which you can use your QSA to decompress it sufficiently. And it's a dynamic process. You decompress it, you come around the capsule, you shrink the capsule, again you decompress. So these steps you continue to do and repeatedly. And you can see that inside is not that very firm, so a little bit it is softer, so it's more amenable for QSA. You can see that on vascular, and then you start using QSA. So you debulk the tumor nicely, you pour it out internally, and you leave the capsule for you to dissect it from the surrounding neurovascular structures. So you can see that. So it's a QSA is doing a very good job here. And sometimes very firm tumors, QSA may not work, but luckily in this case, you can see that the QSA is really doing a good job and it is decompressing. So you repeated it, you repeatedly continue to do internal decompression, and finally you start devascularizing. You can see that once the capsule has become slack, then you go ventrally and you start devascularizing. You can see that the attachment is not one particular point, entire tent and also to the petrous bone under the junction. So this is the main attachment here all over. So you start decompressing it. You should be very careful as you go. Sometimes you may encounter the Dandy's vein at the depth. So you need to be careful. So you can see that. So you can almost you are devascularized, but there's still a little bit more. So you continue to devascularize it, detach the attachments from the junction of the petrous bone, dura, as well as the tent. And you can see that is the branch of Dandy's vein has been dissected off, and that's the final attachment. And you continue to do that, and then finally you will see the Dandy's vein there. And that is the last bit of attachment, and you can see that's the Dandy's vein, and that is a tentorial attachment. You can see the tentorium is also significantly attached here, and that is the final thing. So once you are done, and you can see that the glimpse of the Dandy's vein, you are seeing it at the end. So finally you could lift the tumor out, and you can see you have achieved hemostasis. So that you can see that the cerebellum is lax and not much contusion here, and then so that these are relatively simpler, easier tumors compared to the more deeper ones. So sometimes you see that lot of edema. So that edema will really make the field very tense, angry cerebellum bulging, and especially so we need to take care of that. So there is a post-op MRI. So how good you have maintained the cerebellum, you can use your T2 images post-op MRI to look for really how much you have handled the cerebellum. You can note that. So these are some of the petrous, posterior petrous meningioma. You can see a wide attachment. They go till the IAM, but they are predominantly posterior to the IAM. And you can see that almost a good decompression. Facial nerve preserved. You can see the facial nerve is preserved. It's pushed anteriorly and medially, and that is the point of attachment. You can see that that was the attachment. You can see the entire eye area. The dura also has been removed here. The bone is naked there. Similar tumors. Yeah, so again, large tumors with a large attachment. You can see that, and post-op MRI, you can see the preserved facial function. Sometimes they need not be big. Small meningioma, but this patient had an intractable hemifacial spasm, and so this patient was warranting a surgery. So you can see that it had just reached the IAM, and it was the seventh nerve was getting kinked around here, explaining the hemifacial spasms. Compared to the other tumors, premeatal, the ones which are anterior to the seventh nerve, they are more challenging surgically because you have to work between the nerves to get it removed. And out of all the nerves, seventh, eighth, fifth nerve, lower cranial nerves, the fifth nerve are the more robust, and so they are amenable for handling. So you make that as a fulcrum, and then you go around. But here you have to be very careful because functional preservation is very important. So you always leave behind tumor nodules which are densely adherent to the nerves. I just take you to the video of this, how different it is from the previously seen video. So here you can see that, so that is the seventh nerve complex. There is a lower cranial nerve. You can see the tumor. So it doesn't respect the arachnoid plane. The tumor is encased the seventh, eighth nerve. So you have to be very, very meticulous here. So you start dissecting it gently. You cannot be very rough here because you can develop cranial neuropathy, seventh nerve, hearing loss. And so that is the seventh nerve. Then you go up. So you start. You can see there's a wide corridor between the seventh, eighth nerve and the fifth nerve. So you use this, and that is a petrous apex there. So once you you know the limit of the tumor, then you start decompressing it. Here, the 6th nerve is more vulnerable. So that is the lower cranial nerve, 7th, 8th nerve, and that is the 5th nerve. So you can see that the 5th nerve is little bit more amenable for handling. So you use CUSA finally, and you always find the 6th nerve in between the 5th nerve and 7th nerve complex at that depth. So that will be roughly the landmark for that. You always need to watch it, and then you work around the 6th nerve because they can be easily missed and they can damage the 6th nerve. So you can see that. So slowly you mobilize this tumor carefully, and you work between the above 5th nerve and below the 5th nerve and keep pulling it, and you use CUSA to debulk the tumor sufficiently. And that is the end of the tumor. You can see that that is a brainstem surface and a 5th nerve, and you can see a thin rim of tumor around the 6th nerve entry because otherwise you may cause damage. And you can see, you can always follow up these cases. And so premeatal tumors are premeatal tumors. Sometimes they may be small like this. They are present with trigeminal neuralgia. And you can see that the post-op MRI. Sometimes they can be part of the petroclavial, sphenopetroclavial. You can see a large supratentorial and then going towards the tent and then coming down towards the premeatal region. They are very raw, big, giant tumors. And this patient I operated through a transpetrous approach, and she had a completely preserved function. Sometimes there can be an en plaque meningioma like this, where you see this tumor and you can see that there's a lot of edema here, and you see multiple lobulations, and you know that this is not going to have a good plane. You can see that the irregular margins. So you need to be very careful. So functional preservation is very good. So I had left a thin plaque of tumor around the nerves, and so that patient can be fine. Patient subsequently was given with SRS. So this is the strategy. So you need not be very aggressive in these type of tumors, and you should be careful to maintain the functions of these patients. Vessel encasement, yes, in premeatal tumors, they're really challenging. You can see that the basilar artery is at the tip and there's a cuff of tumor around it. So you need to be very careful here, and always to preserve the vessels, to identify the vessel, and then you trace it. The combination of sharp and blunt dissection. You can see that the superior cerebellar artery here, and then that is the tent, and then you can see that the brainstem. So you follow the superior cerebellar arteries, and then that is a good landmark for you to trace it to the basilar artery, and you can see you use a combination of sharp and blunt dissection, and you can see that these arteries are nicely preserved. They have relatively good plane of arachnoid, and you can see that. So once you follow the artery, you know where that will itself lead to you to the basilar artery, and you know you will not injure the vessels in case. Small perforators will be feeding the tumor, and that is the basilar artery. And you can see that the tumor is being ruled out from the basilar artery and the brainstem. And so that is the strategy to dissect off the blood vessels. You can see that the post-op MRI is a functionally preserved patient. As I was mentioning you, the endonasal approaches are coming up, and there is a role for the endonasal, slightly premeatal and medially placed tumors. Endonasal approaches are not suitable if the epicenter of tumor is much more lateral, where you may not have a good access. And you can see, so they are best approached by retrosigmoid or transpetrous approaches. Vis-a-vis tumor like this, where you see they're more medially placed, and the basilar artery is shifted more medial towards other side, and you can see that you have good plane. And these are the cases where you can have endonasal approaches. So I'll show you the video of this surgery where the basilar artery, so you can have immediately placed lesion. So you have exposed, that is the cella, there's a carotid groove, and that is the clavicle bone. Using navigation, you know the attachment, and you start working on it. So that is the extended endonasal approaches. So you start drilling the clavicle bone. You can see that your advantage is that you are devascularizing the tumor initially itself. You can see under copious irrigation. Sometimes these bones and dura can be extremely vascular. So using these TC is very useful. It will reduce your surgical time. Otherwise, you have to wait for a long time for the hemostasis. And this is really a boon in endonasal approaches, where you can use these hemostats, and then you can get into it. So using navigation, you know exactly where the tumor is, and you expose the dura, and you open the dura, the clavicle dura. The clavicle dura also will be very vascular, but advantage is that you are already devascularizing the tumor there. And you raise a flap of dura there, and then you start seeing the tumor. And so once you make a window of that, again, you can see that the basilar plexus of veins, they can be sometimes very vascular, and they start bleeding, and you can achieve using flow hemostats. You can see that the tumor is fibrous. So you start decompressing it gently, and you can see that you little bit CSF is also coming out, and you use a combination of a blunt dissection and a sharp dissection. And that is the glimpse of the basilar artery which you are seeing here. That is the brainstem. So that's the basilar artery nicely. Now you can visualize. So you have a good now a corridor to work lateral to the basilar artery, and you can see sometimes the plane is not very good. So you may have to use a sharp dissection there. Blunt dissection may unnecessarily cause spinal injury to the brainstem. So you are dissecting it off the brainstem using a sharp dissection. And once you are a little bit decompression is done, so you can start mobilizing the tumor. And you can see that here the brainstem is there. So you come laterally around. You can see once you start debulking it in a short while, you will see the CP angle cistern, and you know that the limit of the tumor. So that is the bluish cistern of the cerebello-pontine angle. And now you know the limit of the tumor. So you have identified medially, laterally, superiorly, only laterally around that. So then that is the thing. So the attachment has been detached, and then slowly you try to dissect it out, and you can see that the entire tumor has been mobilized. So small tumors centrally located on the clivus, centering on the clivus more. So we can see that the tumor is very slippery, and you can deliver it through the nose. And that is the end of the surgery. So you can see a small size tumors. You can see that's a post-op CT scan, the bone work is the. So this is a good corridor for small lesions in the brainstem. Now coming to the last group, the lateral cerebellar meningiomas. You see here that again, as I was mentioning you, the T2 weighted images, you can see a lot of edema, so that causes the challenge. These cases, it's always better to do a MR venogram to know the dominance of the sinus. So you see here, that is a dominant sinus, and that is the side of the tumor. The opposite side transverse sinus is hyperplastic for some reason, and there is no sigmoid sinus. So you need to be extremely careful, and you need to preserve the sinus very, very carefully here. There's a post-op MRI, you can see that this sinus is preserved. So that is something which you should do. Always do an MR venogram. And again, these are not very big tumors, but I had a problem in this case. You can see that the sigmoid sinus was very adherent, and this patient had a rent in the sigmoid sinus, and she had developed IVH. She had a long time protracted recovery. Finally, she made it, and then she is requiring a shunt. So coming to the post-op complications, hydrocephalus, as I showed in the previous slide, chemical meningitis, CSF leak, especially the endoscopic approach, and new onset cranial nerve palsy. These are some post-op complications which you really look forward. Finally, the role of radiosurgery in case of meningioma. I was just going through the literature, and I could find that Stark has a large experience on this gamma knife, and so he has analyzed his data of 255 patients. 43 were from CP angle meningiomas, and in roughly 86%, the tumor volume remained unchanged after 6.5 years. That means it has arrested the growth, but it has not shrunken the tumor. So the tumor remains status quo, and the neurological symptoms also stabilized, or it remains status quo in almost 90%. So there is a role of gamma knife in elderly patients, small size tumors with not much neurological signs, and especially the growing tumors, and also post-operative small residual tumors. So to conclude this talk, most cerebello-pontine angle meningiomas are grade 1. They are fibrous meningiomas, and they can be sometimes very vascular. And a good retrosigmoid approach, you can get the whole of the tumor with a good, excellent results, with good neurological function also. The risk of facial and hearing loss is significantly lower when you compare with the vestibular schwannoma. And in IONM, if it is there, is very helpful. The strategy is to leave behind tumor nodules adherent to the vessel perforators, the cranial nerves, to prevent morbidity, and they can be always addressed by gamma knife or serotactic radiosurgery on later date. Small progressive tumors, incidental, and they are growing, especially, they can be treated upfront with radiosurgery, and you can avoid surgery. Thank you very much for this time.
Thank you very much, Roopesh. And stay for discussion part now. I will ask Dr. Ajit Sinha to introduce the Dr. Sridhar for his talk.
Sir, I think you should introduce him. Everybody knows Dr. Sridhar. He is a very eminent neurosurgeon, and I have seen his presentations and videos, excellent, and he has experience on various type of neurosurgery. So I'll prefer that you should introduce Dr.
Okay. Okay, Adi, thank you. And Sridhar has been a very close friend of mine for the last 3 decades. He had his neurosurgical training under none other than the great Professor B. Ramamurthy. So after his training there, he had been to Chitra Tirunal Institute also as an observer while he was in training. So where I could interact with him, that was in, I think, early 90s. So after he passed out, he worked as a faculty there in VHS for a significant number of years. And then he moved to Calcutta, where I think he knows Bengali also very well. Probably his schooling time, he was somewhere in Bengal also. So it was not a big surprise when Professor Sengupta just absorbed into his place, and he worked there for a couple of years. And then he switched gears back to his hometown, Chennai, where he was heading the Department of Neurosurgery at global hospitals. And there also he did a fantastic job. And then later he moved to now MGM, Medical Health Services, which is still a better place with a big team. And I am sure he's an excellent speaker, excellent organizer, and excellent host. And also I should admire, he has an excellent wife who can just she's such a good hostess also. So with this introduction, may I ask my friend Sridhar to talk on hemangioblastomas, CP angle and cerebellar.
Thank you, Professor Suresh. It was a great pleasure. It was actually 1988 and then 89 that I spent time, and I first came in touch with Professor Suresh Nair and his incredible photographic memory and knowledge of almost every book that you have read or every journal. And that was something which I'm still astounded at. So thank you very much. Thank you, Ajit. So I'm going to be talking on cerebellar hemangioblastoma and a little bit on the CP angle hemangioblastomas as well. If you look at hemangioblastomas, they form about 1.5 to 2.5% of all intracranial tumors and about 7 to 12% of posterior fossa tumors in adults. Now, majority of the hemangioblastomas are sporadic, and when they are sporadic, they are large and single and often occur between 30 to 65 years of age, while the VHL complex are less common. And when you have the VHL complex, the lesions are generally smaller in size in younger individuals and, of course, are multiple. They are perhaps the most common primary intraaxial tumor in the posterior fossa in adults and comprise about 2.5% of all intracranial tumors. Now, the cerebellum is the most common location of hemangioblastomas in the posterior fossa. And in the cerebellum, they are more common in the posterior half of the cerebellar hemispheres. It's also then seen in the brainstem, especially in the medulla, and in the CP angle, they are quite rare. Now, based on MRI studies, Jagannathan et al. In 2008 classified hemangioblastomas into 4 different types. Now, these were hemangioblastomas without associated cysts, with or without edema, those with intratumoral cysts, those with peritumoral cysts, and those with both peri and intratumoral cysts. Now, the presence of a cyst or absence of a cyst has surgical connotations, as we all know. Solid hemangioblastomas occur mostly in the brainstem, cerebellar, vermis, and the spinal cord, while cystic tumors are located primarily in the cerebellar hemispheres. Now, involvement of the brainstem or cranial nerves, it is difficult to understand this preoperatively as to how tightly the tumor is adherent to these structures. We will know that the brainstem or they are in the CP angle or adjacent to the CP angle, but we will never know what the adherence of the tumor is. And it is very important to understand this because getting a radical resection of these hemangioblastomas, which are in close opposition to either the brainstem or cranial nerves, is very, very important. Now, the postoperative morbidity and mortality in the early days used to be about 50% morbidity and an intraoperative mortality of 9%. And it was because of very unsuccessful intraoperative hemostasis. And as far as hemangioblastomas are concerned, I think the only problem with hemangioblastomas is the hemostasis or the bleeding that can happen if you inadvertently enter the lesion, or if you coagulate a large vein, draining vein, and then the hemangioma will enlarge and start bleeding. In 1997, Vaquez and et al. Reported 279 instances of cerebellar hemangioblastomas and found that the larger the tumor, the more the post-operative bleeding was. So from then on, we have seen in reports that size matters a lot when we are dealing with hemangioblastomas. But whatever the size, the technique of excision now is standardized. You have a wide exposure. You don't do hemangioblastomas with a small opening. You always have a wide bony opening and dural opening, because what is needed is a circumferential dissection. You have to go around the lesion. You cannot debulk the lesion like you saw what the previous two speakers spoke with acoustics or with meningiomas. And you need to control the arterial feeders as you go along. Now, however, all that said and done, we still have a problem when large hemangioblastomas are encountered, because en bloc and circumferential dissection still can be a problem. Now, in 2011, Van et al. From China divided the tumors into 4 types according to their location and their arterial supply. So the type 1 was found in cerebellar hemispheres and the vermis, and this was found to be supplied by the superior cerebellar artery, pica, and the ICA. The type 2 lesions were found in the tonsil and lateral medulla, fed by the ICA, pica, and meningeal branches. Type 3 were found in the fourth ventricle and brainstem, fed by the pica. And type 4 found in the superior vermis and dorsal midbrain, and these were fed by the superior cerebellar artery and meningeal branches. When you come to looking at intraoperative bleeding, of course, then comes the question is whether you should do a preoperative embolization. Now, preoperative embolization has been tried and used by multiple authors. It has been found to be useful when the preoperative radiology indicates that it is difficult to control the arterial feeders during surgery. And once you do a preoperative embolization, you can resect the lesion easily because the intraoperative bleeding is significantly decreased. And because of this, the surgical time also is shortened, and you can easily do a total tumor resection. However, it is not without problems, and what the potential complications and problems which have been seen are ischemia, bleeding, a swelling of the lesion with an increased intracranial pressure, and therefore all these have made the use of preoperative embolization still controversial, and very many editorials have come out saying that preoperative embolization may not be the way forwards, but rather looking at the arterial feeders and trying to get the arterial feeders first surgically perhaps would be a safer way to do things. Now, this paper in 2014 by Fukuda et al. Looked at the clinical factors predicting outcomes after resection of sporadic cerebellar hemangioblastomas. They looked at 36 patients which had a mean size of 36.4 millimeters. And what they found that the solid configuration observed was the most important clinical factor to both immediate and long-term outcome after surgery. Now, tumor size, we again find tumor size being mentioned, and surgical resection becomes more difficult with tumor size and outcomes worsen, especially when tumors are with diameters of more than 4 centimeters. However, sporadic hemangioblastomas have better surgical outcomes, long-term outcomes than patients with VHL. In anterior cerebellar tumors and those in the CP angle, which have cranial nerve or brainstem involvement, meticulous dissection of the tumors from vital structures should be performed with electrophysiological monitoring. Now, when you come to the topic of cerebello-pontine angle hemangioblastomas, They are quite rare lesions. Until 2017, only 11 cases were reported in literature. And then came a huge series from Cheng in 2017, where they reported 23 cases in all. Now, when you look at hemangioblastomas as such, looking at these as the cerebellar hemispheres and this as the vermis, this is the brain stem. Normal sporadic solid hemangioblastomas are generally located completely inside the intraaxially, but they always surface at a pial surface. While the CP angle or extraaxial hemangioblastomas can either be completely extraaxial, touching either the brainstem or the cerebellum, anterior cerebellum, and often touching the posterior petrous, or they can have involvement of the pia of the anterior cerebellum or the brainstem. Now, these are very important points because this creates problems or not so much problems when you operate on these CP angle hemangioblastomas. So, like I said, they may be completely extraaxial or they may have involvement of the pia of the adjacent structures. Adherence to the posterior petrous and tentorium has also been seen in these patients. Now, it has a very close relation to the neurovascular structures of the CP angle, and therefore, when you operate on these CP angle hemangioblastomas, meticulous microdissection of these neurovascular structures is very, very important. The approach, therefore, has to depend on the maximal surgical exposure for the tumor location. And of course, the surgeon's ability and familiarity. And we need to look at how we want the patient to be post-operative. Now, when you look at CP angle, it's more common to have solid hemangioblastomas than cystic hemangioblastomas. However, the solid hemangioblastoma showed poorer post-operative outcomes, and they had a higher incidence of post-operative complications. Now, just some cases of hemangioblastomas in different areas of the cerebellum and CP angle in the posterior fossa. This is a patient, a 24-year-old lady with a post-delivery headache. She became disoriented, then developed tonic posturing, and in 48 hours developed quadriparesis, difficulty in breathing. Now, this was a case which was an undiagnosed VHL complex. We found one lesion in the region of the vermis and in the region of the obex, bordering onto the fourth ventricle, and one more in the upper thoracic spine. But this was the lesion which was creating the most problem in the posterior fossa, and therefore we operated on this lesion. So this was a standard posterior fossa midline approach, going down up to C1. And you can see the bulging cervicomedullary junction with the syrinx and cyst here. And this is the region of the obex where we could find the tumor started. So the tumor was started dissection from here, and these are the final circumferential dissection of the tumor, and it was taken out. And at the end of tumor removal, this is the obex here. The entire fourth ventricle was visualized, including the aqueduct. Another case, a 40-year-old male brought to the ER with history of breathing difficulty and cough, and 1 week of drowsiness for 24 hours. He was previously operated for a cerebellar hemangioblastoma, and a VP shunt was also done at that time. The details of that particular case were not available with them. The patient was conscious but had bilateral lower limb weakness. You can see that the shunt was working very well, maybe just too well. And there was a lesion seen in the CT scan in the midline. So this was a large cerebellar solid hemangioblastoma seen in the region of the vermis. Because it was so large and the patient, it was quite a large lesion. So we thought we will do a DSA, and this was the DSA done, which showed feeders from the pica, the ica, and some branches, peripheral branches of the superior cerebellar artery as well. And therefore, we thought, let us do the day before surgery, let us do a preoperative embolization. So this was done, and it was quite successful because you can see the blush is almost completely gone, and we were quite happy with this. But unfortunately, patient deteriorated 6 hours after embolization, somewhere in the early hours of the morning. Next day morning, there was severe brain swelling around it, and therefore the patient was taken up for emergency surgery. We were able to removing the hemangioblastoma was not much of a problem. We increased the previous bony opening to include the foramen magnum and C1. We excised the lesion completely, but because of the deterioration that the patient suffered immediately post embolization, the patient had a very, very stormy period and took a long time to come around. And therefore, I am, after this case, a little wary of trying to get a preoperative embolization for hemangioblastomas to be done. Another patient where a tonsillar hemangioblastoma with intra-lesional cyst present, which was removed. But final case, I'm going to take you to this particular patient, which looked on this MRI, preoperative MRI, in the 65-year-old man, very similar to what Dr. Roopesh showed, a lesion abutting the posterior petrous with edema in the surrounding cerebellum and a little bit on the brainstem as well. If you look at it, the contrast scan, there seems to be attachment to the tent with a little bit of a tail. So we went in with a possible diagnosis of meningioma, but the characteristics were also of a hemangioblastoma. So we were prepared for both, and therefore we did a large exposure. This is the video. So we did a large exposure. This is the I operate with the patient supine head turned, the lax cerebellum, and then we found that the lesion was extraaxial, mostly with involvement of the pia. So what we did was we went into the superior cerebellum and lateral cerebellum first and dissected the tumor from there. There were small feeders coming from the cerebellum into the lesion. As usual, as must be done in hemangioblastomas, the circumferential dissection is what is important. And here we reach the lateral part where CSF, you can see, is coming. And we are careful to put a patty there so that we don't injure the arachnoid, which is safeguarding the cranial nerves. So once that is done, we keep circumferential dissection. The small feeders which are there are taken out. The white matter, we purposely go a little bit into the white matter so that we don't go into the lesion itself. Now, once we do that, and we have reached quite a bit of the lesion, then we look at superiorly. Now, this is Dandy's vein here. You can see that, and that is, you can see this is the hemangioblastoma, and that is the anterior cerebellum, a little bit over there. And that, whatever is the pia sticking there, we take out. And then this is the hemangioblastoma, which is right on the tent and posterior petrous. So using low bipolar settings with a broad bipolar tip, we try to shrink it a bit by coagulating on top so that we can see what is happening. And then we find that it is actually stuck to the posterior petrous with small channels, vascular channels going directly into the bone there. So slowly the lesion is separated. The feeders from the dura and from the posterior petrous are removed. There was a venous channel which went right into the bone, which then was controlled using a bit of bone wax. And the best thing in hemangioblastomas, as you go around, what you can do is put the retractor actually on the hemangioblastoma. And therefore, here you can see the vessel coming from the anterior cerebellum into the lesion. So that is also coagulated and removed. Here, the arachnoid of the CP angle, and here you can see the cranial nerves there. So you keep that arachnoid pouch intact so that you don't disturb the cranial nerves. Luckily, this lesion was superiorly placed and not lateral, and was attached mainly to the tent and the superior part of the posterior petrous. And therefore, we did not have trouble in dissecting it out. This is the anterior cerebellum from which the other feeders are taken out. One must be careful at the last minute to make sure that there are no feeders which are attached to the bottom. And once is sure, and as you take out the feeders, the whole lesion becomes supple, and it is easy to manipulate and rotate the lesion. And once that is done, the lesion can be taken out. So still a small bit of attachment there, a small vessel which is coagulated, divided. And then the whole lesion is taken out as a whole. This is the final view. These are the cranial nerves you can see here. The 7 and 8 lower cranial nerves are there, luckily with the arachnoid intact. This is the 7 and 8 there. So this is the 3-month follow-up MRI, which looks good. And there is no problem with this. So I think in conclusion, post-refossa hemangioblastomas are difficult lesions, especially because the solid lesions and sporadic lesions are often solid and large. And these have to be operated and removed with circumferential dissection. You need to have a large exposure, and so that you can go all around the lesion with meticulous dissection, controlling the arteries first and then the veins last. You must never make the mistake of taking the veins first, because that will swell the hemangioblastoma, and then it will be very difficult to control the bleeding which happens. Whether embolization should be done or not, embolization has its pros and cons. We have burnt our fingers once after embolization, and that makes me personally a bit skeptical about the use of embolization. But there are papers where embolization have been used preoperatively with good results. And like I said, large craniotomies are preferred to access the deep vascular structures. The more anterior the hemangioblastoma is, it's difficult to control the anterior arterial feeders. And perhaps in those circumstances, maybe just those vessels can be embolized and not try for a complete embolization in all the cases. Thank you very much. Thanks a lot.
Thank you, Sridhar. How much time we have, Sridhar, now? Half an hour more?
We got almost half an hour.
Okay. So let me ask my colleague moderator Ajit Sinha to start discussion, and I will join. If time permits, I want to show some more slides to add to these 3 excellent presentations. Very difficult tumors, excellent presentation. Some slides to show some concepts which I have, if time permits. So let us start with Ajit Sinha.
Thank you, sir. First of all, I must admit that all the 3 presentations were extraordinary, and we were to see this all very good experience. So I'll just put few questions to Dr. Sridhar. Regarding the pre-op embolization, I am fond of it and I have a very good experience about it. But what I want to just emphasize that the pre-op embolization should never be particle embolization. The problem with particle embolization is that it goes and blocks the venous outflow, and that leads to catastrophe. In fact, there were papers when they have strictly said that no particle embolization. So I also do the neurointervention work. So I prefer the arterial type of embolization, NBCA, that is n-butyl cyanocrylate. And here the trick of embolization is a little different than the AVM embolization, that here we want to be more conservative. Our idea is that intraoperatively it should be less. So that is what I want to add. And what I think is that even if we don't embolize, if we do pre-op DSA, we'll have a lot of information, particularly Dr. Sridhar, the last case which you were saying, that extraaxial hemangioblastoma and with a lot of vascularity. I think in that case, we'll have fair amount of idea about how much is vascularity coming from the cerebellar parenchyma, that is PAL, and how much is coming from the tent and petrous side. So that is what I want to put. And one query which the common problem which we face is that these hemangioblastoma are mostly associated with cyst, and whether to remove the cyst wall or not. What is your policy?
I don't remove the cyst wall, and I think there are now enough papers to show that however large the cyst, removing the mural nodule is quite adequate.
Right. What I prefer or what I practice is usually after opening the cyst, I inspect from inside. I just put a 30-degree endoscope, rotate once, and if there is any doubtful area, then I selectively remove that also together with the mural nodule. Otherwise, I don't try to remove the cyst wall. I came across one patient of hemangioblastoma where there was, in MRI, there was no enhancement, no mural nodule, but we inspected inside and there was one doubtful area, and we sent it for frozen section, and which was indicative of that. So that's the experience which I want to share. Now, Dr. Nair, sir.
Yeah, thank you, Ajit, for your comments, especially for embolization. And you correctly told particle embolization should be avoided. And Sridhar also insisted that he doesn't say after burning his fingers. He has also stopped embolization unless warranted. Let me just tell about all the speakers before I want to show some slides if possible. So first, Mathew, excellent presentation, and your techniques are good. But only one thing which it is not retromastoid. Always you should tell retrosigmoid, because see, you have to remove the mastoid to see the posterior wall of the posterior aspect of the sigmoid sinus. So always you remove the mastoid. So it is retrosigmoid surgery. The rest of the thing, I will just elaborate the little more surgical techniques, and Roopesh correctly told also about petroclival meningioma. These meningiomas arise medial to the petroclival line, and they also showed various types of meningiomas which can occur there. But one good thing which he told is schwannomas always displace the cranial nerves around, while meningiomas most of the time they are outside, because schwannoma is an extra-axial tumor. Sorry, meningioma is an extra-arachnoid tumor, while vestibular schwannoma, they arise intra-arachnoid, behave epiarachnoid to become subarachnoid again. I will show that concept which I learned after a long time, after burning so many facial nerve, only I realized. And hemangioblastoma is, fortunately for all neurosurgeons, it is rare, especially the locations which Sridhar showed. It is extremely rare to have a tumor there, and the Chinese people always have a lot of numbers. And this location, which is anterior medial location, and as he showed, cerebello-pontine angle location, it's very rare. But sometimes, these VHL patients, they can have endolymphatic sac tumor, which is in that location, which can mimic a hemangioblastoma. So hemangioblastoma patients themselves, they can have a tumor like extraaxial tumor, like what Sridhar showed. It is an endolymphatic sac tumor, where you see lot of papillae. And Sridhar, can I show some slides?
Oh yes, please go ahead.
So can I share the screen?
Yes, I think.
please,
Abhishek, can you just allow him to share the screen, please?
Okay. Are you seeing my screen?
No, not yet.
Now?
No.
Still you are not seeing, eh?
No.
Let me see 1 minute. Oh, okay.
While
In the
sir
meanwhile,
is
can I
going
ask
through that,
Roopesh a question, please?
Yeah, please, yeah.
yeah, please.
Roopesh, hi, excellent talk as usual. Sometimes we find in these meningiomas, they are vascular. They've got small nubbins, and when they are anterior petrous, you have to operate not only between the cranial nerves. Very often, sometimes you don't know where the cranial nerves actually are.
Yeah.
And nor do you know where the branches of the ICA are. What do you do in these circumstances?
That's what, sir. So I feel that dissector, the problem is not there if it is a soft tumor. The real problem, the meningiomas are really very hard. So generally, we know CP angle to some extent, the 7th, 8th nerve location is almost standard. The problem will be the 5th nerve. The 5th nerve will get displaced. So if we can identify the 7th, 8th nerve and then go from below above, then and then we know that we identify the 10th. So we know roughly where the 5th nerve is. And because it is a robust, large nerve, it's quite not very difficult to miss it. So that's how if you show in my video, the soft meningioma, in fact, the 7th, 8th nerve was also having embedded within the tumor. So this nice dissection, I had to just to see. So 7th, 8th nerve is my landmark, and then 10th is the landmark. In between, the problem again is the 6th nerve, more difficult than 5th nerve, is because it's very slender, we can easily injure it. So we need to just put in our time and foot and then identify it because it is at the depth also. Of course, yeah, it's a real challenge to identify, but 7th, 8th nerve and 10th is relatively fixed landmark, so we can work on it, I feel. Yeah, how do you do that?
How do I do that? Oh, it's tough. Like you said, especially if they are vascular. For me, more than the nerves, I'm worried about the ICA and its branches, because very often they are the slender branches coming from the ICA are within the the nubbins of the tumor. Luckily, very often the meningiomas here have a good surface, and therefore we don't face this problem often. But sometimes we get stuck with these meningiomas which have these nubbins and are anterior in location. Suresh, sir.
Are you seeing my screen?
Yes.
Okay. This is classical picture of a vestibular schwannoma. What Mathew showed, this centered on the meatus like that. Sometimes it can have a broad base also. And this is the classical picture of a meningioma. Broad base, some hyperostosis like that. And here, if you see, this is what classical hemangioblastoma T1 hypo, T2 hyper, and it will show this type of enhancement with some flow voids. And this is the classical location. Usually, no, this is not the classical location. This is the rare location. It mimics a CP angle tumor. Extremely difficult, challenging case which Sridhar showed. And what is this tumor? Say this tumor is extending into the meatus. So it is a mimic. You don't know whether it is a vestibular schwannoma, but you are seeing hyperostosis extension inside the canal. So obviously this is a meningioma only. So this is, again you see a broad base here. And then if you compare this, both sides, internal auditory canal, say this type of appearance, usually cystic more appearance is more for a vestibular schwannoma. And now, say this is one paper which was published from Chitradendal Institute long back in 2008. Sometimes, it is very difficult to distinguish between a vestibular schwannoma which doesn't extend into the canal. People, even Al-Mufti, all call it medial vestibular schwannoma. So always what you should do, this type of intratumoral microhemorrhages in heavily T2 weighted image, this is characteristic for a vestibular schwannoma. Usually these microhemorrhages are not seen in meningioma. So those vestibular schwannomas, medial vestibular schwannomas, which doesn't extend much into the internal auditory canal. This is a trick to find out. And this is, vestibular schwannomas can arise in all shapes, size, everything. It can extend everywhere. And now coming to some of the concept. So this saffron colored area people call CP angle cistern. So people consider it as one cistern. It is not one cistern. It has multiple CSS spaces. There is a CSS space which is engulfing the lower cranial nerve. There is another CSS space which is enclosing the fifth nerve, and then there is this acoustico-facial cistern. This is another CSS space, and this space has got these nerves. You can see 7th, 8th, and vestibular nerves. They go right up to the fundus of the canal, and these nerves they come from their sensory nerves. They come immediately. It enters, pierces the dura. There is no epiarachnoid space at all. Moment it pierces the bone, it is inside the arachnoid. So what I am telling is there is no epiarachnoid space. There is an acoustico-facial cistern. Now next slide. This is a toluidine blue stain which shows that arachnoid extends. This acoustico-facial cistern, that acoustico-facial cistern, arachnoid extends right up to the fundus of the internal auditory canal. So there is no epiarachnoid space there at all. And now we know that these tumors, they have, as Mathew told also, they have to arise from somewhere near the Scarpa's ganglia. So Scarpa's ganglia is either at the meatus or somewhere inside the canal. So normally these tumors arise inside the subarachnoid space. It is not the epiarachnoid space as what we have been taught. It arises inside the subarachnoid space in the internal auditory canal. So this is the site of origin. People know that it arises from the Scarpa's ganglia, which is inside the internal auditory canal. And this is the most important picture which I want to tell for all the people who are listening to this talk. This is what we have learned. I have taught so many residents these tumors. This is Yasser-Gill's concept of vestibular schwannoma origin. He always believed that these tumors arise epiarachnoid inside the internal auditory canal. Now we know that there is no epiarachnoid space at all. And so this concept was these tumors, as they arise epiarachnoid, and then they move towards the CP angle, move towards the brainstem. They carry with it the arachnoid, which was inside the canal. And then as the tumor grows, this arachnoid gets juxtaposed to this parietal arachnoid or the CP angle. So any surgeon who operates through a retrosigmoid route or a translabyrinthine route, he has to remove this double fold of arachnoid to get into the tumor. This is what we have taught so many people. Is it still hold good? Now previously I have told that there are so many CSS spaces. One is the acoustico-facial cistern, which carries the cranial nerves inside. And here you are seeing a T2 weighted image. This is a CP angle vestibular schwannoma. You are seeing CSS space lateral to the tumor. So if this tumor arises epiarachnoid, this CSS space should not have been there. So what is the present concept? This is the first person, this everybody knows, is a close friend of India. He's the first person who told in 2002. This article, the Journal of Neurosurgery refused to publish. So he got it published in Indian Journal of Postgraduate Medicine. And what is this growth of vestibular schwannoma? So Professor Ohata is from Osaka City University School of Medicine, close friend of all of us. And this is another man. He is a man with more than 2,000 acoustic schwannoma surgery now. So his concept is, there are two cartoons here. This cartoon depicts a tumor which is epiarachnoid. This cartoon depicts a tumor which is subarachnoid, because you are seeing an arachnoid here. Here there is no arachnoid over the surface of the tumor. What this Professor Kono did in Tokyo, he took a cut specimen from the top of this tumor and sent it for examination. He found that almost all of them have an arachnoid over the tumor. And so they first time they also told these tumors are not epiarachnoid. If it is arising epiarachnoid, there should not be any arachnoid here. If it is arising subarachnoid. There has to be arachnoid over the tumor. Then what is this double fold of arachnoid? The double fold of arachnoid is these acoustic tumors always get adhered to the lip of the meatus. So it arises subarachnoid, then gets adhered to the lip of the meatus, then behave epiarachnoid for a long time. Then it falls, automatically this double fold of arachnoid is formed. This is what all surgeons remove. So if it is a subarachnoid tumor, this double fold of arachnoid, first layer, second layer, you peel off. Then you cannot keep this fold of arachnoid. At some point of time, you have to enter into the subarachnoid space. So acoustic schwannomas arise in subarachnoid, behave epiarachnoid to become subarachnoid. We have seen all the videos of Mathew. They say when you remove the tumor, there is no arachnoid which separates the tumor from the 7th nerve, 8th nerve. While you have arachnoid which separates from the lower cranial nerve. You have arachnoid which separates from the 5th nerve because they are in different systems. So if a tumor arises inside the subarachnoid space, there is no arachnoid. This everybody should understand this thing. Otherwise, everybody will look for an arachnoid. You will never get an arachnoid. This is again Professor Corno's depiction. This is the tumor. This is the tumor. What is the capsule of the tumor? Capsule of the tumor is the perineurium. Capsule of the tumor is the perineurium of the vestibular nerve. And then you see the facial nerve here adherent to the tumor. The facial nerve, there is no arachnoid. This is the arachnoid. So these are all subarachnoid space. You see the tumor. You remove the tumor, you don't see arachnoid separating it from the brainstem. You don't see arachnoid separating it from the facial nerve. That is what Mathew was telling. So you free the nerve in the meatus. Then many surgeons, they just decompress the tumor so that they never get into this plane. More you come into this plane, more chances are there. More you bear the facial nerve, more chances are there facial nerve function will go. That is why these tumors arise subarachnoid, behave epiarachnoid, and ultimately it is in the subarachnoid space only. This every neurosurgeon should know. He will never look for an arachnoid. This is the arachnoid. So if you expect arachnoid to come here, it will never come. And you will damage the 7th nerve. I don't have time to show a video, but then this is true for 98% of the cases. Very few cases like intracochlear, vestibular schwannoma can arise, intralabyrinthine, intravestibular, say vestibulocochlear, transmacular. These are all epiarachnoid. They are very, very rare tumors, transmodiolar, transotic. If these tumors arise here, then they are epiarachnoid tumors. So this is the most important this thing which I want to show. And now another trick is a poor man's way of depiction. This is the internal auditory canal. And so you draw a perpendicular from the internal auditory canal to the long axis of the tumor. So if this is acute, your 7th nerve is usually displaced upward. If it is obtuse, it is displaced downward. This is a Korean journal. It holds good. So you can draw this and see if it is acute, 7th nerve is usually pushed upwards. But these days we have, and now coming to meningioma, this is what CPA, this is petroclival meningioma, this is the petroclival line. So usually these tumors arise medial to the 5th and lower cranial nerves. And this is a meningioma which arises behind the meatus 3 here. We call Cerebello-Pontine Angle meningioma. This is another group of meningioma which is arising in front of the meatus, which is called the premeatal meningioma. This is the true petroclival meningioma. They arise medial to the petroclival, medial to the 5th lower cranial nerve. These tumors arise in front of the meatus. So this is the premeatal. So this is the 5th nerve. So this is the true petroclival, and then this is the area which is premeatal. Here you are seeing the 7th, 8th meningiomas can arise here, which Roopesh nicely showed. And next is, this is the CP angle tumor. This is the most easiest of the tumor. Just I want to tell, because I think both Sridhar and both Roopesh highlighted. Say, always I used to ask a question to my postgraduate. Say, if there is a lateral cerebellar convexity meningioma, if there is a posterior petrous meningioma like this, and if there is a tendorial meningioma, which is the one which is likely to catch the sigmoid sinus? So everybody will tell it is the posterior CP angle meningioma. It is not. Then people will tell it is the tendorial meningioma. That is also not correct. It is the lateral cerebellar convexity meningioma, which is the one which will catch that sigmoid sinus, that area. So this is what I was telling, true pretroclival meningioma. If your meningioma arises from here, it will displace all the cranial nerves posteriorly. 5th, 7th, lower cranial nerves, everything is displaced posteriorly. And if this meningioma arises in the premeatal area, it will displace the, say if you see, this meningioma arises, say it will displace the 5th nerve anteriorly. Rest of the nerves are displaced posteriorly. So 5th nerve location will correctly tell whether it is a premeatal or it is a true pretroclival. True pretroclival will displace 5th nerve posteriorly. Premeatal will displace 5th nerve anteriorly. And you see, so these are some of the typical examples of large meningiomas. And what I told is acoustic neurinomas, the subarachnoid tumor behave epiarachnoid, and again they are in the subarachnoid space. You remove the tumor, there is no arachnoid which separates it from the brainstem. Meningiomas always have arachnoid. Always it is an extra arachnoid tumor. So what Roopesh was telling, meningiomas are more likely to engulf the cranial nerve. But this is a pretroclival meningioma. Sometimes you have double layer of arachnoid. So your chances of protecting the cranial nerves are much easy with the CP angle meningioma or a pretroclival meningioma. All these approaches he has told, and just he never talked about anterior petrous or posterior petrous approach. This is just to tell you a pre-sigmoid approach. Pre-sigmoid approach, if you take for a pretroclival meningioma, you cannot reach here. This is a clival pit. You cannot reach here. So let us look at a retrosigmoid approach. So this is the sigmoid sinus. Retrosigmoid, you can reach the clival pit. That is why many people say they have started using a retrosigmoid approach as a workhorse for even these tumors. This is last of the lot. Hemangioblastoma, always difficult. Always a question is asked, how will you distinguish it from a AVM? AVM also mimic like this. Say AVM, you will not see capillaries. Otherwise, it is just the same. There also circumferential dissection. This is a tumor only. A circumferential dissection, beautifully described by Sridhar. So, if you have an anterior medial or a CP angle, whatever you call, what is the approach? Say, and these lesions, they don't surface posteriorly, and embolic materials correctly, Ajit has told, and also it is just, so these are the approaches. You have translabyrinthine approach, total circulatory arrest, subtemporal transtendorial, far lateral supra-infratendorial. All these approaches are there. First case, myself and Girish Menon did a large hemangioblastoma in this location, anterior medial location. We did under circulatory arrest, and that patient died also. So this is not that case, this is some other case. So thank you very much. I think I have added to what this beautiful seminar, all these speakers have taught us. Thank you.
Thank you, Professor Suresh Nair.
Thank you very much.
Ajit, would you like to conclude?
Yeah, it was an excellent presentation indeed. And at the end, sir's experience we could hear. And it is always a pleasure to hear him. And we all agree that on all the three topics, he has literally added new knowledge. Every time he speaks, I am always keen to listen. He always comes out with that new concept. And we are all, we do admire that. I just wanted to ask sir, as well as Dr. Matthews, that what happens, like which one you give preference, Like suppose if you are removing the acoustic and you find that it is easily coming out, but the facial nerve stimulation, the EMG shows that continuously the facial muscles are getting stimulated. Do you still go ahead and remove completely, or you want to leave a small bit adherent to the nerve, as is advocated by many of the authors, that you leave a little bit of nerves
That is a
adherent
good
to that?
question. Like, many other people, they want to leave some tumor, thinking that more radical you remove, you damage. I remove tumor. Say if the tumor is coming out, it is a good day for you. And if you are in the correct dissection plate, I should have shown one video because this was not part of my talk. I would have shown, say that Mathew showed how we dissect with that sharp scissors. Or you have SS forceps. It is a fantastic small pointed tip forceps where you decompress the tumor, decompress the tumor, decompress the tumor. Tumor will fold. Then take these forceps. Start scratching over the tumor surface. Slowly, that arachnoid will go like that, and then you can start seeing the nerves. And next time, if Sridhar gives me a chance to talk, I will show these videos. Actually, that I had shown in
We'll love to
Sridhar's,
see that, sir.
Sridhar's meeting. I
Next time,
had shown.
definitely
If
will
he
love.
comes out with that YouTube of that, you can see there. Okay. I try to remove the tumor if it is coming out.
So yeah, with this, I like to thank all the speakers. The presentation was excellent indeed. And may I request now Dr. Sridhar to say anything
Professor
if you want?
Suresh, can you just stop sharing your screen?
Yeah. Okay.
Yeah. Thank you. So I think we have had a very, very stimulating and a great academic evening. So thanks to Professor Suresh Nair and Dr. Ajit Sinha, and of course to my good friends, Professor Mathew and Professor Roopesh, for giving their time and their fantastic presentations. It's been a pleasure, and I think it's a wonderful evening that we have had. So I will now hand over back to Suneet and Abhishek for wrap up.
So thanks.
Sridhar, there are two questions. So
Yes.
which I think one is what to do for multiple hemangioblastomas. You can, Sridhar, if you can answer, or you just respond to their questions later.
Yeah, I'll type off the answer. Yeah.
Okay, fine.
And so there's one more question about current status of sitting position in CPA surgery.
Sitting position in CP angle, Mathew, would you like to answer that?
I think it's a personal choice. There are a large number of centers which prefer the sitting position. It has basic advantages that you get an additional hand as a suction. The blood seems to flow. But I personally do not use the sitting position because of a couple of reasons. One is as the case gets prolonged, there is an element of fatigue as far as the surgical team is concerned, because the position and the microscope is sitting directly forward. Second thing is that if you have a very good assistant with you, the lateral position utilizes him better. He has a much smaller cone of approach when you have a sitting position. This, I think, it's again a personal choice. I think it will, as you become experienced, your choice of position, it's better to try one or two times a position for a reasonably similar tumor. Ultimately, you will know what.
I have operated more than 1,000 CP angle tumors. I have never operated in sitting position, but always lateral position. And some tumors I have operated in supine lateral. As Mathew was telling, it is personal choice. Like Atul Goyal, always he operates in sitting position. And I think if you have a very good anesthesia team, a sitting position also is a good option. But it is difficult for somebody who has got bull neck, very, very stout bull neck or basilar invagination, stout neck. there is very difficult. Or if you have a posteriorly placed sigmoid sinus, inferiorly placed transverse sinus, it is very difficult to operate in sitting position. So otherwise, it is personal choice, Peter.
So Suneet, can you wrap up now?
I would like to again say big thanks to all the participants, speaker, and chairpersons. It was a great evening, and I'm pretty sure that we all have got a lot to learn from this. And we'll definitely be bringing this kind of series on a monthly basis, like a Tumor Thursday. So it will be on a Thursdays. And again, as a wrapping up comment, again, I would like to say big thanks to everyone. Thanks. Good evening.
Thank you, everybody, and see you next month on a Thursday.
Thank you,
Bye-bye.
Sridhar.
Have a wonderful
Thank
evening.
you,
Have a
Ajit.
wonderful
Thank
evening,
you,
everyone.
Jindal. Thank you, Mathew, Roopesh, Abhishek, everybody,
sir.
and all the participants. Good night. Bye.
Good
Take
night.
care.
Bye, sir. Good night.
Good night, sir.
Bye.